Good morning. When early in April I was tasked by the GFN Scientific Committee to deliver a talk on COVID-19 and smoking, I said to myself, this is cool. This is going to be a piece of cake. We all know that smoking is detrimental to bacterial and viral infection of the respiratory tract. And certainly the same logic will apply to the novel coronavirus too. And I thought with some relief that the task ahead would have been easily and successfully completed in no time. But how wrong I was. Weeks after weeks, days after days, the balance of the evidence seems to be swinging from pros to cons and back. Believe me, it is kind of frustrating when dealing with moving targets. But in the end, here I am to deliver what I think is a balanced overview of COVID-19. Now, the cut I intend to give to this talk is twofold. In the first 3-5 minutes, I will illustrate the human-virus interaction and what that means for the individual in terms of COVID-19 clinical outcomes, meaning degree of severity, disease evolution, resolution, and death. I believe this is very important because it allows me to give you an idea of the clinical complexity and the clinical spectrum of the disease. In the remainder of my talk, I will reassess these interactions and pathways under the specific lens of the individuals who smoke, and by doing so, we'll be providing the best evidence available to date. The picture here illustrates a typical interaction between the individual and the virus. In the case of coronavirus, the interaction and the outcome of this interaction, whether it's leading to a more severe disease or to a asymptomatic form of the infection, depends simply on two factors. Factor number one is the viral load. Factor number two is the level of immunocompetence of the host. We know that for the specific case of SARS-CoV-2, 80% of the population seems to deal adequately with this viral infection, developing only a symptomatic infection or mildly symptomatic disease. And prognostically, this is extremely positive because the evolution is always and inevitably towards recovery. But not all people encountering the virus will end up having a symptomatic infection or mildly symptomatic disease. The less fortunate, about 20% of those encountering the virus with less efficient immune system or those who are exposed to a high load of virus, will develop a more serious form of the disease and will end up in hospital. Here, the hospital environment is represented by this colored geometrical form. Evolution is common, so moderate cases can quickly evolve into critical cases in a matter of days. In a matter of days, people can die. It goes without saying that there are individual characteristics of the host that will favor hospitalization for COVID-19 or evolution to more serious form of the disease or even death. In this slide, it is illustrated an analytical tool that by condensing all the information available from case series from all over the world, provides an estimate of the most important risk factors for severe COVID-19. And you see for yourself very clearly that age and multiple comorbidities emerge as the most important risk factors for COVID-19. Okay, elderly people with multiple comorbidities are extremely vulnerable to the serious consequences of COVID-19. Agreed? The evidence is overwhelming. Case closed. But what about smoking? Plausibly, one vulnerability to severe illnesses from COVID-19 would be assumed to be cigarette smoking. Why? Because it is known to increase the risk of serious respiratory infections. But is this true for the novel coronavirus too? Do we have evidence for this? Okay, let's pause a second and take a quick step back focusing on viral infections. In this slide here, it is illustrated the data from a recent systematic review that emphasizes 2 points. One, smokers are 5 times more likely to be infected with the influenza virus than never smokers, so indicating susceptibility to infection. And 2, smokers are on average 34% more likely to develop flu than never smokers. And this indicates susceptibility to viral illness. The question now is, do we expect similar susceptibility in smokers for novel coronavirus as for influenza? Okay, let me repeat myself. And please, let's take a very good look at this slide. So smoking can interfere with the different process that we've illustrated so far. Smoking can interfere at point number 1. So the question is, does smoking increase susceptibility to SARS-CoV-2 infection? Or does smoking increase susceptibility to asymptomatic or mild COVID-19? Or let's focus on the impact of smoking on point number 2, which is, does smoking increase susceptibility to COVID-19 hospitalizations? Or finally, let's focus on the impact of smoking on point number 3, which is, does smoking increase susceptibility to COVID-19 outcomes, whether it is severity, progression of severity, ICU cases, ventilated cases, or deaths? Okay, in the next 10 minutes, I will try to systematically address each and any of these points using the best available scientific evidence. Good, let's start. Point number 1. What is the scientific evidence for the smoking increasing susceptibility to SARS-CoV-2 infection as well as asymptomatic or mild COVID-19? This is the first study. This was carried out in France, is a retrospective closed cohort study, has a cross-sectional design. In this study, the authors have included 661 students from high school students, single high school students, including parents, siblings, teachers, and not teaching staff. They were asked to fill in questionnaires about the clinical data, including respiratory symptoms since January 2020 and the smoking status. This sample was also subjected to venipuncture for serologies for coronavirus. The number of seropositive in the study was 171 out of 661, which makes nearly 26% of the total cohort. But the most interesting finding is that smokers were 4 times less likely to be infected by the virus. The French study has a number of caveats. Most notably, it's a small sample size, and most of the population was recruited among young high school students, which are likely to lie about their smoking status. However, the second study is clearly of better quality. This is a cross-sectional core study selecting people amongst the population registered with about 500 GP practice. Their clinical data and smoking status was already recorded in their electronic databases. Out of this large population, 3,802 individuals underwent swab testing for SARS-CoV-2, and 587 tested positive, 15%, just over 50% tested positive for the virus. All the demographic, clinical, and smoking variables were extracted from the electronic medical records. And this data was linked to disease severity, need for ventilation, and mortality data that was extracted from the hospitalization record. And again, here we see exactly the same findings that we saw in the French study, that smokers are less likely to be infected by the virus. And they're going to be approximately half of the smokers will be infected compared to never smokers. There is also, interestingly, some data about former smokers, and the former smokers were 13% less likely to be tested positive compared to never smokers, thus indicating some loss of protective factors somehow. I believe very interesting information that is derived from this large study is that risk factors that are normally associated with COVID-19 outcomes are not relevant for the population of this particular study. So they are not relevant for general population or for population that are not hospitalized with COVID-19. It is likely the risk factors for the infection that are important for infection susceptibility are very much different from those risk factors that they are more relevant for development of the disease. But even the large GP studies carried out in the UK has flaws and limitations. For example, there are quite a number of missing values amongst the electronic medical records, and there is always the possibility of selection bias because the people that have been swapped were individuals with symptoms. But most of these problems are completely addressed in this other study from Israel. This is a case-controlled population-based study. Again, the clinical and smoking variables are extracted from electronic medical records available at one of the most important health provider of that in Israel, and they screened and swapped the whopping number of 114,000 plus individuals, and of these 4,537 tested positive for swab results, which is 4%. This data was then linked to disease severity, need for ventilation, and mortality data that were extracted from hospital records. So here we are talking of a very large, good quality study. It's in fact a case control study. It is unlikely that selection bias is occurring in this population. And the findings, again, is that smokers were less likely to be infected by the virus. So current smokers were 54% less likely to be tested positive compared to never smokers. And for former smokers, the percentage was a bit lower, but still significant, with about 20% being less likely to be tested positive compared to never smokers. Perhaps you've noted the striking similarities in between these two studies. The GP-based study and the Israeli study, and not only in terms of the so-called protection from viral infection conferred by smoking. In fact, in both studies, half of current smokers were less likely to be tested positive compared to never smokers. But these similarities are repeating also in this slide, where again, risk factors normally associated with COVID-19 outcomes are not relevant for general population. And this, again, was already shown in the GP studies from the UK. Perfect. Let's go on. Point number 2. What is the evidence for smoking to increase susceptibility to COVID-19 hospitalization? Let's go and address this point too. Perhaps the first published study investigating the association between smoking status and hospitalization for COVID-19 was the study of Al-Khatani that has been published in the PLOS One a month ago. It is a study that includes COPD patients as well, but there is also separate data for smokers from 8 studies for a total of 1,790 patients. To cut a long story short, this meta-analysis shows that the smokers are less likely to be hospitalized for COVID-19, simply because the evidence is deriving from the fact that only 9% of the prevalence for smokers being hospitalized is about 9%, whereas the expected prevalence is at about 27%, which is 1/3 of the expected prevalence, indicating protection. Although the Al-Khatani study was probably one of the first published in the literature, it suffers from a number of flaws. It's a small study. Most of the data sets are coming, basically all data sets are coming from China. It uses a fixed model for the analysis, and it doesn't take account key covariates that are known to have an important impact on COVID-19 hospitalization. The next study here by Konstantinos Farsalinos addresses most of these caveats. It's a much larger studies. Here, Konstantinos has included 30 studies, 13 published and 17 are pre-publications. it uses a random effect for the meta-analysis and adjust from some key covariates such as age. We know age is very important confounder, and sex as well. And the findings from these 30 studies that accumulates a total of over 10,000 observations is that, again, current smokers are less likely to be hospitalized for COVID-19. Next point that we have to address is point number 3. What is the evidence for smoking to increase susceptibility to COVID-19 severity, progression, or death? To address that question, Konstantinos and co-workers have carried out meta-analysis of the association between current, and this time versus non-current smoking for adverse outcome. Definition of adverse outcome is fairly broad, but in general for adverse outcome we intend some level of severity, people being ventilated, and in some cases deaths, COVID-19 deaths. The data is derived from the same very list of 30 studies. So again, the meta-analysis will investigate a total number of more than 10,000 observations, and the conclusion is that the current smokers are more likely to suffer from COVID-19 adverse outcomes compared to never smokers. In 6 of those 30 studies, it was possible to evaluate more in detail the impact of smoking status on adverse COVID-19 outcomes. And in this particular meta-analysis, still from Farsalinos and colleagues, it was possible to try identify what is the impact of current versus former smoking, and the conclusion was that the former smokers were more likely to suffer from COVID-19 adverse outcomes. And one of the explanations is that probably people who quit smoking and then they are categorized as former smokers are those people who suffer from most severe smoking related disease, and that can explain why these are most at risk for adverse outcome for COVID-19 and not just for COVID-19. We return here to comment on the Israeli study that we have illustrated before, and as expected, in the case of severe COVID-19 outcomes, there is an evidence of an association between chronic comorbidities and COVID-19 severity and or death. So that is expected, with some notable exceptions, to be honest. If you carefully look into the table, COPD, asthma, and BMI are not listed as important covariates for the severity of COVID-19. To add to this little confusion, please have a look again at this Israeli study. And this time the Israeli authors are looking not at infection rates, but at the COVID-19 outcomes. So severity of the disease and fatalities. And it is surprising that this time there's no impact of smoking on COVID-19 severity and fatalities. And this is somewhat in line with the lack of COPD association with the COVID-19 outcomes that you can see in this slide here. This is going to be the final study I'm going to present to you today. It is a cross-sectional core study of a GP registered population of adults. Their demographic, clinical, and smoking variables were extracted from their electronic records kept at the GP's practice. The data was then linked to hospital COVID-19 notifications, and the authors found 5,683 COVID-19 deaths in this GP registered population. The findings from this GP-based study is, as expected, that age, sex, body mass index are, along with a long list of many others, clear risk factors for COVID-19 death. The findings of this GP-based study are intriguing, to say the least. In fact, the study suggests an increased risk by 25% only in former smokers, whereas there's a slight protective effect, only 12% protective effect observed in current smokers. So, I mean, it's very unclear what is going to be the impact of smoking on COVID-19 death, particularly if we put together also the other population-based study, which is which is a good case control study carried out in Israel. Very well. If there is any verdict to be drawn, I think this needs to be taken into consideration all the methodological issues that are revolving around all these papers. Of course, I don't have the time to delve into every single one of these methodological issues. All I really want to say is very simple. You are all aware that scientific journals have been swamped by a huge number of COVID-related articles. As of 8 June 2020, more than 21,000 papers have been published in less than 6 months. It's about 116 new papers every day. That's madness. And just figure it out. In the world of electronic cigarettes, you have published less than 5,000 papers in 10 years. This is just to give you an idea of what is the problem that many editorial teams have to deal with. The haste in fast-tracking such a large number of COVID-related research, in my opinion, is likely to be highly detrimental to the quality of the publications themselves. And as you can imagine, speed is not necessarily a friend of good quality science. Yes, articles are being assembled hurriedly, publishing processes being fast-tracked to their very limit, and the quality of peer review has suffered a lot. So the research that we see today, and not just on the area of smoking and COVID, but most of COVID-related research is likely of being of poor quality and requires further scrutiny. And on that note, let me conclude by saying that whether smoking or tobacco smoke is truly protective for coronavirus infection or for COVID-19 outcomes, is not yet certain. And the jury is still out. But the mounting evidence do not point at smoking as a risk factor, at least. It's not a risk factor for those susceptibilities. And as a consequential educated guess, given that combustion-free nicotine delivery systems are much less toxic than combustible cigarettes, let me tell you that vaping and using hidden burns is highly unlikely to be a risk factor for infection and or disease. Thank you.